Good morning. I am presenting a case of traumatic posterior dislocation of lens with secondary glaucoma. A 64-year-old male presented on 1st of December with redness, pain and diminution of vision following injury to right eye with a heavy iron pipe while repairing his vehicle at home 2 days back. After consulting nearby hospital, he was prescribed prednisolone acetate eye drops, antibiotics and homemade eye drops in right eye. There was no history of any other significant ocular disease or surgery or lenses in the past. He had systemic hypertension and chronic kidney disease. He was conscious, well-oriented with stable vital parameters. Right eye ocular examination showed uncorrected visual acuity of hand movements with less than N36 vision, normal lids and adnexa, circumciliary congestion with corneal edema, anterior chamber was deep with 3 plus cells and mild dispersed hyphema, a blood clot in the anterior chamber at 4 o'clock position. Iris showed iridodontis with 6 mm dilated pupil with vitreous at the pupillary margin. He was aphakic. There was dispersed hyphema and posteriorly dislocated lens shadow was identified in the inferior periphery on dilated fundus examination. His intraocular pressure was 46 mm of mercury with ablation tonometer. D-scan was done, which showed attached retina with dispersed vitreous hemorrhage and high reflectivity corresponding to the lens in the vitreous cavity. Left eye was having uncorrected visual acuity of 6.9 with anterior segment showing nucleus sclerosis grade 1 and Cubis ratio of 0.5 with normal macular vessels and periphery and normal intraocular pressure. This is a picture of right eye showing mild corneal edema with deep anterior chamber with a blood clot at 4 o'clock position and aphakia and normal left eye. He was diagnosed as traumatic posterior dislocation of lens with secondary glaucoma in right eye. Was admitted, started on prednisolone eye drops, 2-hourly atropine, tristain in right eye, oral analgesics, and topical anti-glaucoma medications, timolol, brinzolamide, brimonidine, and ipazodel. And he was given injection betamethasone 2 cc IV tab. As patient had a history of chronic kidney disease with raised creatinine and urea, it was making it difficult to administer full dose of IV mannitol and oral acetazolamide. After nephrologist opinion, he was given a tailored dose of 100 ml intravenous 20% mannitol and 250 mg of acetazolamide tablet once daily. He was kept under constant input-output monitoring along with serum electrolyte monitoring and was started on sodium bicarbonate tablets also to prevent metabolic acidosis secondary to acetazolamide. Then the patient was planned for cross-planar vitrectomy and lensectomy after intraocular pressure control. But intraocular pressure remained high for 4 days despite medications, making the posterior fundus view difficult due to the persisting corneal edema. On the 5th day, intraocular pressure came down to 30 mm of mercury and corneal edema started resolving. And he was taken up by the vitreoretinal department for pars-planar vitrectomy and lensectomy under local anesthesia in right eye on 9th of December. He was discharged after that with prednisolone eye drops 4 hourly, moxifloxacin eye drops 4 hourly, and atropine eye drops thrice daily, timolol eye drops, brimonidine, brinzolamide eye drops twice daily in the right eye. And he was reviewed on postoperative day 15 with best corrected visual acuity of 6/18 and 8/10. Conjunctiva had intact corneal sutures and cornea showed few dismissed membrane folds. AC was deep, anterior chamber was deep with occasional cells. He was aphakic with Cubis ratio of 0.5, retina was attached, and intraocular pressure of 7 mm of mercury. Thank you.
Yeah, it was managed just like any other pars-planar vitrectomy, lensectomy, nothing great in that. It was a routine surgery. But 2 points I would like to bring in here. Here the patient came with a trauma, a dislocated lens, a secondary glaucoma, and a lot of corneal edema. And the patient was pressurizing Maya to get the surgery done as early as possible because he wanted to finish it off and go, and Maya was pressurizing me. So we had to resist that temptation of going in when the pressure was 45 or 50. Patient had a renal problem. We had to take the nephrologist's opinion for treating him with systemic drugs. And we brought down the pressure in 4-5 days, and then we went in, and it was an extremely safe procedure at that time. So that was the first point which I would like to bring in here. Control the intraocular pressure in such a condition before going in for a pars-planar vitrectomy lensectomy. The second point here is in a traumatic dislocation, I would suggest that scleral fixated lens or an iris supported lens should not be done in the same sitting because there could be so many other parameters which we have to go and do an angle study, see how the pressure goes, see how the retina is, and then gradually, maybe 1 month or 1.5 months down the line, if everything is all right, then we can go for a scleral fixated IOL or a nice iris supported IOL and not in the same sitting. So these are the 2 points which I would like to bring in here. Thank you.
I thank Dr. Maya and Dr. Thomas Turin sir for their presentation. Now over to panel discussion.
Again, I'm not very clear what was the slip up, except that you pressurized sir doing it. So the slip up is there. That is how you manage a traumatic case. You wait. You don't do immediately remove the lens. What is the hurry in that? I mean, there is nothing to, as long as you have to see the cornea edema, you can't do surgery. You have to wait till it clears up. The inflammation has to come down. So I don't think there was anything wrong in what waiting of another this thing till it clears up. So I am not sure what exactly your slip up was and what exactly did sir change.
Ma'am, actually, giving the medications in this patient with raised creatinine and urea along with raised blood pressure was the difficult situation for me. And to give the patient for surgery after low blood pressure control.
Actually, I would say that there is no mistake in this. There is the slip. I would say there is a slip because what is the cause of glaucoma? Did you evaluate that?
Sir, patient had high fever induced, probably trabeculitis along with the blockage of trabecular muscle with the inflammatory mediators and the RBCs.
I do not think that there is any slip here because pressure was high, 45, and the problem of going inside with a pressure which is very high is sometimes you can have decompressive retinopathy and a central retinal vein occlusion picture picture can come in, or even an expulsive hemorrhage can occur when you have very rapid reduction of the pressures. So it is right that we reduce the pressures. Now we were not able to give Diamox and Mannitol, and in renal failure patients you have done other maximal medical management. But in an inflamed eye, I would try to increase the dose of the usual anti-glaucoma medications, because all these anti-glaucoma medications which are given 2 times and 3 times are based on non-inflammatory eyes. So in inflamed eye, the turnover would be much rapid, and probably just like you would put more steroids or more antibiotics in an inflamed eye, more times, probably that can help a little bit in this. Was an inferior PI needed?
I didn't do an inferior PI because by the time we took up for surgery, the pressure was controlled. We could clear the vitreous entirely. So I didn't go for an inferior PI. AC was formed.
No, did you finish the surgery with an air bubble or gas bubble?
No, neither air nor gas.
Request Augustine sir again to give away the mementos to the.
The next talk is on idiopathic ERM, hidden dangers. Mentee is Dr. Nikita Ann, Consultant Cataract and Medical Retina, the Eye Foundation, Kochi. And the mentor is Dr. Praveen Murli, Consultant Vitreoretina Services, the Eye Foundation.